Go ahead, okay. So I'm gonna start in the interest of trying to get everyone out at the end of this long day. So I wanna thank everyone for coming. And I'm thankful to have the opportunity to talk today as well. My name's Chelsea Kotch. I am a pediatric neuro-oncologist at the Children's Hospital of Philadelphia, and I work in both the neuro-oncology and neurofibromatosis multidisciplinary clinics. And I have the opportunity to speak with you all today about Plexiform Neurofibroma, and I'm going to try to cram as much information as I can into an hour about kind of the overview of Plexiform Neurofibroma and neurofibromatosis type 1, the management of these tumors, and then ongoing and upcoming clinical trials that we'd really like the community to be aware of. So just disclosures, I do receive some research support from NTAP and the Gilbert Family Foundation, and then there are some medications that I will discuss today that are not approved yet for the treatment of Plexiform neurofibroma. So NF1 associated nerve sheath tumors occur in a couple forms. We have cutaneous neurofibroma, which are on the surface of the skin or immediately beneath the surface of the skin. Plexiform neurofibroma, which tend to be deeper or more diffuse tumors. Atypical neurofibromas, which represent a tumor between the spectrum of plexiform neurofibroma, and then the malignant peripheral nerve sheath tumors, which we think occur in 8 to 13% of individuals with NF1. So I'll primarily be talking about plexiform neurofibroma today, but I'll reference some of the other tumor types as we move along. So plexiform neurofibromas are histologically benign tumors, and I put the word benign in quotations because I think many of us know that while they are called benign tumors, these are not in fact benign in their behavior or character or symptoms that they can cause. They occur in about half of individuals with NF1, and they're thought to be congenital, meaning present at birth, but they may not be apparent in infancy and may grow or present later in life rather than at birth. They typically grow along nerves and nerve branches below the skin and within the body, and they can be diffuse with less clear borders, meaning when you're potentially feeling your own plexiform neurofibroma or physician is feeling it, we're unable to tell where it starts and stops. We diagnose plexiform neurofibroma primarily based on history in the office, asking about symptoms that may have changed, pain, new lumps or bumps or skin changes that may suggest an underlying plexiform neurofibroma, and then marry that with a physical examination and a neurologic examination. We obtain imaging, specifically magnetic resonance imaging, which has no radiation exposure, if there are concerning symptoms or the potential for a plexiform neurofibroma. And rarely do we require biopsy or surgery to confirm the diagnosis of plexiform, because really we can make this diagnosis based on exam and imaging alone. There is a very classic appearance of plexiform neurofibroma, and I want to highlight that these are images of larger plexiforms so that people are able to visualize them on the screen. But you can see that they range from that on the left occurring next to the spine or paraspinal to the face or neck or chest or arm. And these pictures were actually taken on MRI without contrast, meaning there was no dye given through the IV. We use special imaging techniques on MRI that could make plexiform quite bright, and we're able to delineate the borders without the need for contrast exposure. Now, I mentioned that we don't need to do a biopsy or surgery to confirm the diagnosis of plexiform neurofibroma, but there are rare instances where you really should do what we call a tissue diagnosis. And this is really when there are features that are concerning for malignant transformation or change. So this would be growth of a single nodular lesion within a plexiform neurofibroma that particularly was not previously growing. Change in the growth pattern or rate. If you come into the office and you're saying, you know, the plexiform neurofibroma on my arm has started growing quite rapidly or has changed in its appearance or texture, that is something that you may want to obtain imaging and consider biopsy for, because those are signs that there may be some transformation to malignancy. And then rapid growth patterns, so not just growing, but having kind of an explosion of growth. And we use that estimate meaning greater than 20% in a year of volume, particularly in patients that are older than 15 years of age. And I'll get to why that age cutoff in a couple slides. But really, it's these changes in growth, changes in pain, changes in texture that you start to say, is there a change in this plexiform neurofibroma where it's moving into or transforming into what could be a malignant tumor that needs immediate treatment? Now, I'm not sure if we've heard the term atypical neurofibromatous neoplasm of uncertain biologic potential yet today, or ANUBUP or ANUBUPI, depending on where you heard it first. But these are kind of a new classification of atypical neurofibroma. So those tumors that fall between plexiform neurofibroma and malignant peripheral nerve sheath tumor. And these are tumors where we're not quite sure where they fall on the spectrum to MPNST. They're not an MPNST yet. They're some way on the pathway, but not all ANUBUPs or atypical neurofibromas progress to MPNST, and we don't know which ones will or will not. So the current recommendation for these tumors is complete surgical resection, if feasible, if it occurs within a bed of plexiform or an isolated area, because we're trying to prevent that malignant conversion. And when you do a biopsy of that concerning tumor or that potential ANUBUP, we recommend genetic testing of the tumor. So not testing of all of the cells in your body to see what your NF1 gene mutation is, but actually testing of the tumor to characterize what genetic changes or changes in the DNA or genes of the tumor have occurred that may suggest this is more likely to be a malignant peripheral nerve sheath tumor, depending on whether or not it looks like that under the microscope. So really, if you're having an ANUBUP or an atypical neurofibroma that undergoes a biopsy or resection, we really do recommend targeted genetic testing of the tumor to help guide clinical decision-making. The natural history of plexiform neurofibroma is one of the areas where there has been a lot of research in the field of NF1. And we know because of this research that most plexiforms grow relatively slowly, with faster growth typically seen in younger children, which is shown in the figure in the middle, where the growth rates of plexiform neurofibromas are higher, meaning the tumors are growing kind of more quickly and getting larger in younger ages, and then tends to peter off or grow less quickly as people approach adolescence or adulthood. We do know, however, that no matter the age, increases in plexiform size can be associated with increased pain and changes in function, like strength or weakness. There has been an anecdotal belief that plexiform neurofibroma growth accelerates during puberty. And there were two separate studies done by the Children's Hospital of Philadelphia and the National Cancer Institute that examined the relationship between puberty and tumor volume, where what we did was actually went through and did something called Tanner staging, which is a special physical exam that tells you where exactly you are along the process of puberty, whether or not you're just entering, in the middle of puberty, or after puberty. And then we looked at the volume of plexiform neurofibroma over time on MRI and found that there was no correlation between tumor growth rate and puberty, meaning the tumors did not accelerate as patients were progressing through puberty. And rather, we found that the plexiform growth rates were higher before the age of 9, actually before people entered into puberty. So there are a lot of reasons to fear puberty, but plexiform neurofibroma growth acceleration does not appear to be one of them. So when we think about treating plexiform neurofibromas, and I want to pause and highlight that this is based on available treatment options and our knowledge of plexiform neurofibromas at this time. So the indications that I talk about are continually evolving and changing and may be different in 1 to 2 years from right now. But right now, what we recommend is that most plexiform neurofibromas can be observed without intervention or treatment unless they are causing morbidity, such as pain or weakness or significant disfigurement, or they're growing and continuing to grow. And for plexiforms without morbidity, if they are growing, things to consider are the rate of growth, the tumor location, patient age, and impending morbidity. Is it a tumor that's in the chest that's growing slowly and may start pushing on those important blood vessels? That would be one that I would favor treating to try to prevent the development of morbidity. But the selection of surgical versus medical therapy should really incorporate input from both the surgeons, such as neurosurgery, orthopedic surgery, plastic surgery, and the medical doctors like neurologists or oncologists when making decisions about whether or not to do surgery or a medical therapy for plexiform neurofibroma. So the things that I think about when I'm meeting an individual with a plexiform neurofibroma, and the caveat being I take care of children, so this is typically having a conversation with parents rather than the child themselves. But when I think about how to approach treatment, the first thing I think of is surgery. So can this plexiform be removed without significant morbidity? Meaning, if we do, not myself, one of my brilliant surgeons that I work with, if they do a surgery, is there the potential for more pain, more disfigurement, more weakness? And then could this be accomplished in a single surgery? Or am I going to need to have my patient come back for multiple surgeries over time? That, when weighing that risk and benefit, when those things start to emerge, I think less likely to recommend surgery. Because also, what is the recovery time? You don't want to be in the hospital for an extended period of time when you have, again, going back to prom or summer camp or things that this may significantly impact quality of life if we were to recommend surgery for this plexiform. So if surgery is not a feasible or good option when thinking about risk-benefit ratio, the next question that I think about is there an available tumor-directed therapy, such as a MEK inhibitor or a clinical trial? And when I think about MEK inhibitors, the question is, are there specific safety issues or concerns about using a MEK inhibitor? Is there a reason that this medication would not be safe to start in this individual with a plexiform? And then what is the duration needed to get effect? Someone mentioned earlier about having tumor next to the spine, and I think particularly about plexiform neurofibromas being near the spine. If you have a tumor that's growing and compressing the spine and starting to cause weakness, a MEK inhibitor may not be the best option because if that takes a couple months to have effect, the damage to the spinal cord may already have occurred. So we may recommend surgery in that instance for a quick reduction of that pressure on the spinal cord or that pushing on the spinal cord to prevent permanent damage. And then also, what are the clinical trial opportunities? Are there promising medications that are available and that may be a good fit for that individual with the plexiform? And then concurrent to this, and that was a great talk by the speakers before this, things that we think about concurrent to the treatment of the tumor or tumor-directed therapies are there complementary pain medications, physical therapy, integrative health, other treatment approaches that we can optimize pain and function while also thinking about ways to treat the tumor itself. So we really need to have a multidisciplinary team with surgeons, pain medicine, psychologists, oncologists, and then shared decision-making with the patient and the family about what the best fit is for that individual and that plexiform, because it's clearly not a one-size-fits-all. So when we think about the approach to plexiform for surgery, complete resection remains the only curative therapy for plexiform neurofibroma. However, resection or surgical removal of the entire tumor is often limited. And this is because these tumors can surround important body parts, such as blood vessels or the airway. They can have a significant risk of bleeding because they often either involve blood vessels or have their own blood vessel supply. And then the nerves, because these are peripheral nerve sheath tumors, the nerves run through the tumor or are part of the tumor. So you can imagine that getting an entire tumor out would mean taking or sacrificing those nerves, and that itself can cause pain and significant weakness. So there are many risks to doing an aggressive surgical debulking, and we know that tumors, if they are growing and we do not get the entire tumor out, they will continue to grow after surgery most of the time. When we think about other tumor-directed therapies like radiation therapy, we do not recommend that for the treatment of plexiform neurofibroma at this time. There is unclear clinical benefit, and there is a known risk of secondary malignant cancers. So we do not recommend radiation for the treatment of plexiform neurofibroma. For drug therapies, such as traditional, what we call IV chemotherapies or cytotoxic chemotherapies. These have been examined in clinical trials for plexiform neurofibromas and have not shown a benefit. And what we need to consider when we're thinking about conventional chemotherapies is the potential risk of secondary cancers, because there are some IV chemotherapies or even oral chemotherapies that carry a risk of secondary cancers. So you do not want to give an individual that has a tumor predisposition syndrome a medication that may elevate their risk further for a secondary cancer. And then finally, which I'll talk a lot more about in a couple slides, are the molecularly targeted therapies. So until recently, these were all experimental, but excitingly, we now have 2 FDA-approved therapies that are molecularly targeted therapies for the treatment of NF1-associated plexiform. So I want to take a step back and kind of highlight the molecular pathway that we're thinking about when we're talking about NF1-associated tumors. So neurofibromin, which is shown here in the yellow, acts as a brake. And what it really does is it keeps the cell proliferation, survival, and kind of cell growth low. When you lose that brake, when you have a germline NF1 variant, and then you have a change in cells that results in a second loss of NF1, so you lose 2 NF1 genes, that's when tumors grow and develop, and you lose that brake, the cells grow, divide, spread, and you develop plexiform neurofibromas. So there have been many clinical trials, a Herculean effort over the past couple decades, looking at targeted therapies for this pathway to try to put the brake back in. And really, you can see listed here on the right, there were many studies that showed no clinical or minimal benefit for plexiform neurofibroma. And it wasn't until the identification of mitogen-activated kinase inhibitors where we found some success in targeting this pathway. So those successes have been seen in the studies of selumetinib, binimetinib, mirdametinib, and trametinib. And then I'll also highlight another drug called cabozantinib that doesn't act through MEK, but has also been shown to be effective for plexiform neurofibroma. So it's through this identification of these MEK inhibitors that this has resulted in 2 FDA-approved medications. So going back to the early 2000s is when MEK inhibitors were initially identified to be effective for plexiform neurofibroma, and this was first shown in NF1 mouse models, where the drugs were given to mice that had plexiform neurofibroma, and they decreased in both size and number. This supported the subsequent clinical trials of MEK inhibitors in humans. And I want to pause because I would imagine that some of the clinical trial terminology is new to many or some people in the room, as it was to me when I started out. But phase 1 is a clinical trial that many of these drugs have been evaluated in, and phase 1 clinical trials are studies where we're looking for dose finding and safety. So we're saying what is the right dose to give individuals with the tumor of interest to minimize the side effects, but increase the likelihood of treatment response. It's phase 2 studies where we're treating a larger number of patients and we're saying how effective is the drug. So we found that dose that we want to use and we say how effective is the drug at doing what we want it to do. Phase 3 are even larger studies, and those are studies where you're usually comparing a new medication to the standard of care. So for example, and I don't know if Dr. Avery talked about this earlier today, but the phase 3 clinical trial of carboplatin and vincristine, so those are conventional chemotherapies versus selumetinib for low-grade glioma and NF1, that is a study looking at standard of care therapy, carboplatin and vincristine, versus a novel therapy, and seeing if there is equivalent effectiveness between the two. So in plexiform neurofibromas, the benchmark has really been set as partial response being our outcome of interest or what we want to occur. So a partial response of a plexiform neurofibroma is a 20% or more reduction or shrinkage in tumor volume from baseline, which is when the clinical trial drug started. And we typically depict this through waterfall plots where the bars pointing down means there was tumor shrinkage. And then on the left, you see a dashed line, and on the right, you see a red line. And the bars that are pointing down that cross those lines, that means they had a partial response, and that means we considered them a responder in the clinical trial. So why that's helpful to understand is selumetinib was the first phase 1-2 trial, so 1 and 2, that demonstrated high rates of partial response of plexiform neurofibroma to a MEK inhibitor. And these rates were quite promising at 71% and 68% respectively. But not only did the tumors shrink in size, but there was a clinically significant improvement in pain scores and improvements in patient-reported outcomes like quality of life and functional outcomes, such as weakness. So the FDA approved selumetinib in April of 2020 for pediatric patients with NF1 plexiform neurofibroma. And this was the first FDA-approved medication for plexiform neurofibroma ever. I want to highlight the importance of some of the natural history study data that individuals with NF1 selflessly participated in to give data to the NCI so that we could understand how plexiform neurofibromas grow and change over time. And it's with this data that they were able to show the drug company and the FDA and everyone in the community the difference between how plexiform neurofibromas were expected to grow and how that was changed when selumetinib was given. And what's shown on the left is the blue is the natural history data where the little dots are how the plexiforms grew over time, and you can see those increasing in size over time. And the red represents individuals who were treated with selumetinib, and you can see those were relatively flat. And then depicted on the right is what we call a curve that shows how tumors progress over time. Selumetinib is in the red, and what you can see is that the tumors did not progress much, as opposed to those that were not treated and were simply observed on the natural history study because there were no effective therapies available at that time. Those continued to grow and progress as time. So it's in this significant change in the natural history of the tumors that supported the approval as well of selumetinib. There is an ongoing SPRINKLE study. So this is also a phase 1 and 2 study of the selumetinib granule formation in children 1 to 7 years of age. So a SPRINKLE is a capsule that has these little sprinkles in it, for lack of a better word, or granules that you break open and you can mix in food or water. And why this is so important is while selumetinib is approved for children, it comes in a pill. And it's really hard for kids to, honestly, it's really hard for adults too to swallow pills. So we need an alternate option that expands the availability to our community for individuals that can't swallow a pill. So the SPRINKLE study is ongoing, and there will be a poster that's presented as part of the meeting following this. But the goals of this study were really to examine the safety and tolerability, the absorption and distribution of the drug in the body, and tumor response. So those results will be forthcoming. I want to swing to another MEK inhibitor that there's been a lot of excitement about and it's been in the news recently. It's mirdametinib. So actually, the initial clinical trial of mirdametinib was done through the NF Clinical Trials Consortium as a phase 2 study for adolescents and adults with inoperable or progressive or morbid PN. And the study goals of this phase 2 study were to determine the rates of tumor shrinkage, toxicity or side effects, and then quality of life and pain. And what they found was 42% of adults had a partial response or greater than 20% reduction in tumor size. And this really set the stage and supported the subsequent larger RENEW study, which is a phase 2b study of mirdametinib in both adults and children with symptomatic plexiform, where individuals were treated 3 weeks on and 1 week off. And importantly, there was a non-pill form available that could be mixed in water. And there was a confirmed partial response observed in 41% of adults and 52% of children. And like with the SPRINT study, there was improved pain and quality of life measures. So this led the FDA to approve in February of 2025 mirdametinib for both adult and pediatric patients in both a pill and dispersible formulation, thus expanding the age and kind of formulation that is available to the community. There has also been another phase 2 clinical study of a MEK inhibitor called binimetinib, and this data has not been published yet. But in the phase 2 study of binimetinib that was led by the NF Clinical Trials Consortium, 70% of children had a partial response, and of those, 79% had a response by 4 months. And then in the adult stratum, 65% had a partial response, but actually at the lower dose, after some adjustments to the dosing to adjust for toxicity, 82% had a response at the lower dose. So I alluded to the side effects. MEK inhibitors have significant side effects that we are still learning how to optimize supportive care for to minimize the side effects. And in young patients, the symptoms are primarily mild rash, such as eczema in those who are prone, nail bed infections or paronychia, damage to the eyes, or developmental changes. In teenagers, symptoms may have severe acneiform rash, nail bed infections, weight gain, tiredness, or stomach problems. So in an attempt to find other effective therapies that may have differing side effects or non-overlapping side effect profiles, there was another medication, cabozantinib, that does not target the MEK pathway like the MEK inhibitors do specifically, but it targets other cells in the environment of the plexiform and also blood vessel growth and formation. And when this was given to mice with plexiform, it decreased the tumor number and size significantly. And this supported the subsequent phase 2 study of cabozantinib, that was led by the NF Clinical Trials Consortium, where they observed 42% of adults or teenagers that were treated on this trial had a partial response. And because of this potential for a second effective therapy for plexiform neurofibroma, the cohort and study was amended to include a subset of children who are aged 3 to 15 years of age to evaluate how cabozantinib was effective for that age range. And those results have not yet been published. However, cabozantinib also has significant side effects. And shown here in the right pictures are something called palmar-plantar erythrodysesthesia, or PPES for short. And that can cause significant morbidity and can be very difficult to manage when you're receiving cabozantinib. It can also cause changes in your hormone levels or hypothyroidism, stomach or gastrointestinal problems, and high blood pressure. So clearly, we are still working to identify effective therapies, but also trying to identify therapies that do not have such significant toxicities. So it's through the effectiveness of selumetinib and cabozantinib as monotherapies that we've started to ask the question, what happens if we combine these medications together to get better responses? Can we get deeper responses, meaning more than that 20% benchmark? Can we get more people to respond? And what happens if we reduce the doses of both to try to decrease the side effects, but get the same amount of plexiforms responding or reducing in tumor volume? And actually what was done in the Clapp laboratory by Dr. Clapp was they took cabozantinib and selumetinib together at lower doses and gave it to mice and found that the tumor number and size decreased significantly compared to monotherapy or vehicle alone. So meaning at these lower doses, it was still quite effective at reducing tumor volume and size. So this supported the study that hopefully will be open soon. It's a phase 1b/2 study of selumetinib in combination with cabozantinib for adolescents and adults with progressive or morbid plexiform neurofibromas. And the phase 1 part of this study will really be determining the optimal dose and safety and side effects, and then the best dosing combination. So highlighted in green are the normal doses for selumetinib and cabozantinib, and then the gray bar is what we're starting at for this study. So we hope that we're able to find an effective combination that minimizes toxicity, but it may require some adjustments in the first part of the study where we find that optimal dose. And that is being led by the NF Clinical Trials Consortium as well. So we have a lot of important unanswered questions for the use, particularly the use of MEK inhibitors for plexiform neurofibroma, which are, what is the optimal duration of treatment? Do we treat for 2 years, 5 years, 10 years? What is the risk of rebound growth? If we stop the MEK inhibitor, will the tumor start growing right away? Does it grow faster than what it was beforehand? What are the long-term side effects? The SPRINT study has done a great job of capturing longitudinal side effects and longitudinal changes, but we still don't know 10, 20, 30 years, what do these medications cause in the long term? And then are there different doses, different dosing strategies? Do we need to take selumetinib every day by mouth twice a day, or can we adjust the timing or dosing a little bit to mitigate or diminish toxicity but still maintain that effectiveness? And then I think a really important question that's come up is there a difference between the MEK inhibitors that are available now? Should I be taking selumetinib or mirdametinib? Why is my physician recommending one over the other? How do we investigate this data? And really the answer right now is we don't know. It is wonderful that we have two effective medications, but it is impossible to say if one is better than the other at this time. So some studies that are trying to address these unknown questions, and bear with me because this study that I'm about to talk about has multiple moving parts, and Dr. Andrea Gross has actually had to explain it to me a couple times, so I'm going to try to present it to you on her behalf, but don't hold me to judgment. So NF114 is a selumetinib Plexiform Neurofibroma secondary prevention trial. So what this study is trying to answer is how common are plexiform neurofibromas, particularly asymptomatic plexiforms that we don't know about in children. And then in another part of the study, answering the question, should asymptomatic plexiforms in high-risk locations be treated to prevent tumor growth and morbidity? So as I mentioned before, the indications for tumor treatment at this time are presence of morbidity or a growing tumor. But what if we treat earlier? How does that change the risk-benefit ratio of treating the tumor, and does it actually improve outcomes? So part one of the study will answer the questions, what is the incidence of plexiform neurofibroma? So it will enroll young children, and they will get whole body MRIs. So young children that have no known plexiform, they will get whole body MRIs, and we will be able to say how many children have plexiforms that we do not know about. And then we will look at them as well and say, how many children have plexiforms that are in high-risk locations that we may be worried about and may want to treat? And then how do these tumors change over time? So every child that's enrolled on this study, that participates in the study, will have a whole body MRI at baseline and then a whole body MRI 5 years later. And that will tell us in childhood, do new plexiform develops? How do they grow over time if they're not being treated? So that will give us more information to help support our treatment-making decisions. The second part of the study is asking the question, does early treatment with a MEK inhibitor prior to the onset of symptoms prevent the development of morbidity? And this is specifically for children that are identified to have a tumor in what we would consider a high-risk location, such as involving the airway or adjacent to the spinal cord. And this part of the study will take children and randomize them, which means assign them to an arm of treatment. So the typical approach is you are identified to have this plexiform that is not causing symptoms, so we watch. We get serial MRIs, we don't start treatment. So some children will be randomized to the typical approach, and then some children will be randomized to start treatment right away. And what we'll do is over time compare who develops complications of their tumor, side effects, unexpected changes in heart function or lung function or things like that, and then say, does starting treatment earlier prevent morbidity and potentially improve outcomes for children with NF1? And that may change how we make decisions about treatment up front when a plexiform is diagnosed. So this study is not yet open, but we hope that it will be open soon and enrolling patients, and will answer some of these really important questions and improve our understanding of how these MEK inhibitors can benefit children and their families. So I want to swing the other way away from children and talk about an ongoing, open, active study for adolescents and adults with NF1 plexiform neurofibroma. It's called NF119. It's led by the NF Clinical Trials Consortium. And this is a phase 2 study of Helix 1502, which is actually a compound that's approved for the treatment of urinary tract infections that's been used since the 1960s. And it's currently in studies for bladder cancer. But what is amazing is this compound was identified through an artificial intelligence drug discovery platform as effective or potentially therapeutic for plexiform neurofibromas. And then when it was looked at in the mouse model, it was found to function just as effectively as a MEK inhibitor, but it actually doesn't appear to impact the same pathway as the MEK inhibitors. So it doesn't appear to inhibit MEK, but we actually don't know how it works for plexiform neurofibromas. So this study is ongoing. It is taken by mouth 3 times a day, so that's something to think about. But we're hoping that this represents an alternate effective therapy, particularly for individuals who may not be able to tolerate MEK inhibitors or may have a contraindication, or just as another therapeutic option. So that study is ongoing. There is a big move towards understanding the long-term outcomes of these therapies. And one way that we are addressing many of those questions that I mentioned that are the unknowns of these therapies are through a long-term outcome study that's being led through the NFCTC. The short name for it is NF Extend, for extended follow-up. So for normal clinical trials, the way they function right now is you receive the clinical trial medication. So say you're on the cabozantinib clinical trial through the NFCTC. You get treated for 1 to 2 years, you come off therapy, and we don't know anything after that. We don't know if you needed to immediately go on to another treatment, how quickly your tumor started growing again, if it started growing again at all. And a way that we are trying to help answer not only the short-term effectiveness of these medications, but the long-term, is to have this optional study for NFCTC clinical trial participants to enroll for us to be able to gather information with permission longitudinally. So this is an observational clinical trial where enrollment will be offered at the time of enrollment on an NFCTC study like NF114 or 113 or 119, where we examine long-term heart function. We capture echocardiogram data in the future after you've been on therapy or off therapy into adulthood, or the rate of other cancer development or other tumor development. And then also looking at need for repeat treatment, such as going back on the clinical trial drug or needing to get surgery. And then also patient-reported outcomes. So asking about school, work, pain, we're really trying to minimize the number of questions that we ask because we don't want the burden to be on clinical trial participants, but at the same time, we think it's really important to understand how these drugs are impacting quality of life. So this study will be opening soon and will be offered to all NFCTC clinical trial participants and actually offered to people who participated in NFCTC trials in the past for us to really try to get a better understanding of how these drugs affect quality of life and health in the long term. So I want to summarize the kind of whirlwind of information that I've gone through. Based on our current knowledge and current available treatment options, the indications for treatment include morbidity or symptoms related to plexiform neurofibroma and progression or growth if the tumor is inoperable. MEK inhibitors are a very exciting treatment option, but they don't shrink tumors completely, and there are several side effects which can be unacceptable and intolerable. And then there are other medications that may be effective like cabozantinib, but this also carries its own unique set of side effects. And so we really need to move research forward to identify more treatment options that are less toxic and equally effective and available in multiple formulations so they're not restricted to just one certain set of people that can swallow pills or certain set of people that can tolerate certain medications. So the next steps are looking at the use of MEK inhibitors as preventative medications like in NF114 studies of new drug combinations to potentially mitigate toxicity, like NF113, and then long-term follow-up of clinical trial outcomes like NF Extend, in addition to all of the concurrent natural history study and other retrospective and quality of life study that are ongoing to improve our understanding of how to really optimally use these medications. So I want to acknowledge all of the site PIs and study personnel and NFCTC Operations Center, because I talked about a lot of data and clinical trials that are not my own today. And then I just want to thank everyone again for hanging in with me at the end of the day. And I will take any questions.
Hi, thank you so much. This was a super informative talk. My question was just in addition to the pharmacological interventions, is there any credible work going on things like lifestyle modification, diet modification, things that may not be chemical in nature that might be kind of either preventative or sort of useful in tumor modification, pain modification, et cetera?
Yeah, so I had the opportunity to review a lot of the clinical research that was coming into the conference that is adjacent to this conference. And there are many studies that are looking at optimization of quality of life through meditation interventions for pain, looking at supplements of vitamin D and certain other supplements. We really haven't identified or nothing's been kind of put out into the community as effective yet, but there is a push towards understanding complementary and alternative, not only just systemic therapies, but also things like meditation, yoga, massage, integrative therapy approaches that can optimize outcomes and kind of the health surrounding a plexiform neurofibroma as well. So there's nothing that is being presented on a large scale right now, but hopefully that is coming down the pipeline, because I agree we need to be thinking about what other therapies we can integrate as kind of a holistic approach for care. Yeah.
Is there a somewhat of an upper size limit for a cutaneous neurofibroma before you are suspicious that it's plexiform? In other words, is a 3 centimeter cutaneous neurofibroma likely a plexiform?
So that's a great question, and that's where that piece about physical exam really comes into the important part, because what you're looking at is you're kind of looking at the depth of the cutaneous neurofibroma. So I'll start with, say, a large, like what we call pedunculated, or kind of large extending cutaneous neurofibroma. You want to kind of feel the borders, kind of feel how deep it's going. And sometimes, honestly, you may need an MRI to say, what is the depth of this tumor? And is it a plexiform neurofibroma that's kind of growing out or expanding kind of exophytically or out? Or is this a large cutaneous neurofibroma? So there's not a size threshold that I use, because I have seen some cutaneous neurofibroma that are quite large, but it's more about the kind of depth and base of the tumor and the quality that it feels like, and then sometimes what I'm seeing on imaging, how deep it's extending, because we would not expect cutaneous neurofibroma to be extending down into the kind of depths of the nerve.
Is a 6 millimeter punch biopsy, is that usually enough to establish whether it is plexiform or not? Is there are they diffuse? Can they be plexiform in one part and just cutaneous?
Yeah, they do. Sometimes they have very unclear borders, and there may be kind of a contiguous extension of that plexiform neurofibroma with an overlying cutaneous neurofibroma. So sometimes it can be hard to tell where the plexiform stops and the cutaneous neurofibroma starts, particularly on exam, if there's kind of a broad base to the cutaneous neurofibroma and the plexiform itself is more superficial. But oftentimes you can kind of discern on examination and imaging some distinction. But I would think a punch biopsy, based on what we see histologically, is typically enough tissue for us to be able to say what the pathologic diagnosis is. I want to caution, though, that the diagnostic approach for malignant tumors, there's sometimes the tumor can be quite heterogeneous, and if the MPNST has grown in a plexiform or grown from a plexiform, you often need a biopsy in multiple places because you may miss that malignant element. So it's really important when you're doing a biopsy of a plexiform that you're worried about that the person that's doing the biopsy, like the surgeon or the interventional radiologist, knows, because they need to biopsy across a couple areas.
One more quickie.
Yes.
Do neurofibromas increase in size and number during pregnancy, or is that a myth?
I wish I could answer that question. So when we looked at, when we did the puberty study, we also looked back at the data for pregnancy. Obviously, that is more difficult to control for, and we don't see pregnant patients at the Children's Hospital of Philadelphia. However, in looking at the existing literature, there was not what we call a quantitative measurement, meaning when they published that they increased in size and number during pregnancy, it was based on patient report and not using MRIs or other measurable tools over time. And it was actually quite a small number of patients, and it was survey-based. So they may increase in size and number during pregnancy, but what we really need to do is look at that more objectively and then figure out what ways we could approach kind of intervening. Because at this time, we don't recommend the use of MEK inhibitors during pregnancy as well.
Thank you.
Yeah.
Really just a clarification for me. You said very early on that the plexiform neurofibromas are considered congenital?
So that's
historically?
Yeah, so they historically have been considered to be congenital in nature, meaning that there is some cell that's present at birth that subsequently gains alterations that causes the area around that cell to grow. But it's impossible for us with current imaging techniques to say whether or not that's true. But the thought is that the kind of predisposition or potential for plexiform development is present at birth. But that's all kind of anecdotal and historical rather than biopsy proven.
Okay, gotcha.
Yeah.
Just want a clarification.
Yeah.
Can you repeat who should be in the long-term outcome study? My son is on the one that starts with the M. I can never pronounce it. And he's in his third year. Like, is he somebody that I should be looking for that? Or is it people
if he's
in the
on
other
the
ones?
murtimetinib study, that was the pediatric murtimetinib arm was...
He's an adult.
He's an adult. This is why I'm blinded by the light. So if it was the adult murtimetinib study through the NF then yes, he would be eligible. But if it was through the Renew study, then they have their own long-term follow-up arm. But I can help you figure that out after too.
Thank you.
Hi. So one of the things, my daughter has a plexiform right near her spine that they can't feel. So some of the criteria you obviously can't tell. It's pretty deep inside. And there's a lot of challenges with actually measuring the size of the tumor.
Yeah.
And so, of course, we get the information in my chart as quickly as they do. And the first few times it looked like it had grown quite a bit. It's like obviously a concern. And then, 2, 3, 4 weeks later, they've looked at it 20 different times. And now they're like, well, maybe I think we just measured in a slightly different spot. And so at the hospital she's at, they do a ton of things with the 3D printer. Mm-hmm. They do little baby hearts and all sorts of stuff. And I'm like, could you not just make a 3D print of her tumor and then make it again next 6 months? And I know that's a super non-scientific basic question, but we were told there is software out there that 4 or 5 places in the country have that they can actually do a volumetric measure of the MRI. It just surprised me with it being software that it was so limited in the number of places that had it. At the time we asked, even Hopkins didn't have it. And the fact that it's software, it's also wow, how expensive is it if it can be shared electronically? So just curious, that's a very loaded question, but the volumetric, when you don't have the other things, and she does have pain, so it's how much pain? And is that the reason? Because you also have scoliosis. It's hard. It's just the measurement becomes the one thing that we look at to see if there's a malignancy, and it's hard to measure.
Yeah, you've highlighted a challenge and a frustration that because you're trying to put a 2D measurement on a 3-dimensional structure that can even, like, the size can change if you're bent a little bit or you've changed or shifted your positioning a little bit. And it is frustrating because oftentimes the radiologist will say no growth, and then we look at it and we're like, no, this is clearly grown. They're obviously it is expanded in some dimensions. And there is a shift and an emphasis actually at the meeting following today about expanding availability of volumetric techniques, because we actually don't have that as standard of care at CHOP, and that is frustrating to me because I want to be able to say, have we reached that threshold where I would push for treatment, as opposed to, it hasn't really grown, and sometimes we're in that gray zone of like, oh, are you just kind of smushed a little differently in the scanner, and it doesn't feel, based on the rapid explosion of knowledge regarding AI and other techniques, why we haven't gotten there yet. But there is a push to be able to expand this software and show that it is reliable. The problem right now is that the software has really been only used in clinical trial settings, and it's somewhat user dependent in terms of the accuracy. So the goal is to try to expand that software, but also train more people to use it. But we're not there yet. But I'm very hopeful that in the near future that it's going to become more available, because also when I'm talking with families and patients who are receiving a MEK inhibitor not as a part of a clinical trial, and they're asking, has my tumor responded? I can't say, oh, it's 20%. Like, I'm not getting volume. So a lot of what we do is say, has your pain improved? Like, what do you think? Like, it looks a little smaller on MRI, but it's really unfair to not be able to also have those real world volumetric measurements to say, yes, you are deriving benefit, or maybe we should try something else. So you kind of hit the nail on the head of many of our frustrations regarding imaging for plexiforms.
Thank you. It's exciting to hear you're talking about doing something different, so that's good. Thanks.
Yeah.
I have a related follow-up question. So as parents, we're often told that to look for rapid growth or an increase in pain in a plexiform neurofibroma, and that might be a sign or indication that it might be turning malignant or has that propensity. But for a young child, they can't always articulate that. So I'm just curious what a previous speaker alluded to, that there were other signs that you're seeing in imaging that could indicate that a PN can be turning to a malignant tumor. What are those signs? Yeah. I just want some encouragement that besides pain or size and an increase in pain, there's some other indicator. I'm hoping.
Yes.
And I'm just curious about that because we've never really been given that information.
Yeah, so, and actually that's a great question, and I actually may add pictures to slides in the future, because there are some, what we call kind of, you expect the plexiform to look kind of that diffuse bright, because those pictures that I showed in the beginning, that it just kind of looked diffusely bright. And sometimes you have areas of what we call hypointensity or dark spots that can be suggestive of necrosis or change within the plexiform, and that can signify that there may be some malignant change or some cancerous change. Or you can get these nodular portions within the tumor that are growing kind of out of proportion to the rest of the plexiform, and that also is a concerning sign. So whenever there's some subtle changes, so I mentioned we don't typically use contrast, which may or may not be the standard at your institution. I will say that there are really not a standard guideline for how to image plexiforms or at what frequency, whether it's annually, every 6 months, never. There really is not clear guidance at this time. However, I would say that most of us will image a plexiform at some frequency after it's identified, particularly in young children, and not use contrast. But if there's a change in the kind of diffuse brightness or a new nodule or some signal change that does not fit with the rest of the tumor, then we recommend getting a PET MR. And that is, it gives you a special a special dye that can help highlight metabolically active areas of tumor. And you're looking for higher signal or more metabolically active areas. And if it's not present, then you say, oh, this may just be kind of a subtle change within the tumor, but if it's higher, then that may prompt biopsy. So it's so challenging because plexiforms can be painful. We talk a lot about pain, and then we say, oh, but if you're having pain, that you should be worried about malignant transformation, and that can drive people crazy because you're like, but we're having pain now. So what are the markers we're looking for? So it's not just pain alone. There are other things that we can see or feel or texture or nodular. Like there are some signs that radiologists are attuned to and oncologists or neurologists as well when reviewing the imaging. So I don't know if that helps you feel any better, but there are signs, yes.
Thank you for your super informative presentation. I would like to ask, because besides the two MEK inhibitors that are already on the market, you also mentioned there are also other drugs or compounds that are during their phase 2 clinical trials. Can I ask, are these compounds are being developed by pharmaceutical companies, or are they initiated by researchers, and what can be their next steps?
Yeah, so it's a mix of investor-initiated and pharmaceutical-driven studies. The majority are not registration studies, meaning trying to push drugs forward to the FDA. That is typically done when we think that we've found a therapy that is effective enough and we will get enough funding and investment to move that forward. So there are some nuances to drug development, and a lot of the drugs that are used, particularly for plexiform neurofibroma or pediatric cancers, are repurposed drugs, meaning they were initially developed for lung cancer or a non-NF associated condition, and then found to be potentially effective for NF1, and then introduced to the NF clinical trial setting.
Thank you so much.